COVID-19, vaccination and pregnancy, training for healthcare professionals working in the maternity settings. This module was prepared by the HSE National Immunisation Office. This presentation will cover COVID-19 vaccinations, its importance in pregnancy, recommendations, safety and how vaccines work. What is your role as a healthcare professional? Frequently asked questions, making every consultation count and motivational interviewing, vaccination and breastfeeding, and additional resources.
COVID-19 vaccines given in pregnancy include Comirnaty Pfizer-BioNTech and adapted vaccine Nuvaxovid XBB 1.5. This is only given if there is a contraindication or a precaution to an mRNA vaccine. The pregnant woman can receive it as a booster. And a relevant healthcare professional should engage in shared decision-making with the pregnant woman in advance of vaccination. Previously used COVID-19 vaccines in pregnancy include COVID-19 Janssen J-Covan, which is only recommended by NIAC now for those over 50 and is not currently in use in Ireland. Spikevax Moderna and adapted vaccines were recommended for those 30 years and older who were pregnant, but is no longer available in Ireland.
COVID-19 vaccines given in pregnancy include bivalent vaccines, mRNA vaccines, which were introduced to improve coverage against Omicron variants. They were adapted versions of the original Comirnaty and Spikevax vaccines. They were modified to target Omicron subvariants in addition to the original strain of SARS-CoV-2. Comirnaty Omicron XBB 1.5 is a monovalent vaccine which has been introduced in September 2023. The adaptive vaccines authorised by the EMA for use in Ireland include Comirnaty Original Omicron BA1, which is no longer in use, Spikevax Bivalent Original Omicron BA1, which is no longer in use, Comirnaty Original Omicron BA45, which is still used for primary courses, and Spikevax Bivalent Original Omicron BA45, which is no longer in use. Comirnaty Omicron XBB.1.5 is the new vaccine in use for boosters. The National Immunisation Advisory Committee currently recommend mRNA COVID-19 vaccines remain the preferred choice for use in pregnancy. NIAC recommends the preferential use of the new XBB.1.5 adapted monovalent vaccines for boosters. Bivalent mRNA vaccines should continue to be used for the primary course. COVID-19 vaccines, including boosted doses, may be administered at any stage of pregnancy. Those who are pregnant should be up to date with their COVID-19 vaccine in line with NIAC recommendations based on their age and risk profile and time since prior vaccination or infection. COVID-19 vaccines can be given at the same stage or at any interval with other vaccines recommended in pregnancy, including flu or pertussis vaccine. In terms of booster timing, for pregnant, adolescent and adults, a COVID-19 booster vaccine is recommended once in pregnancy. If a pregnant person has not had a previous COVID-19 booster, the first booster dose is recommended at least 4 months after the last COVID-19 vaccine dose or SARS-CoV-2 infection. For pregnant persons who have a booster prior to pregnancy, they should receive a booster once in pregnancy and at an interval of 6 months or more since the last booster dose or SARS-CoV-2 infection. Booster doses can be given at any stage in pregnancy, but ideally should be given between 20 and 34 weeks. If it is more than 12 months since their previous COVID-19 vaccine or infection, administration earlier in pregnancy should be considered. For those who are pregnant and are immunocompromised, a second booster dose within the same pregnancy may be considered if 6 months has elapsed since their last booster dose or SARS-CoV infection. Why is COVID-19 vaccination important in pregnancy? Pregnant women are at similar risk of COVID-19 infection as non-pregnant women. Higher rates of COVID-19 in the community mean the risk of infection is higher. Pregnant women are at higher risk of severe illness in pregnancy and in the early postpartum period. They are also at higher risk of serious pregnancy-related complications compared to non-pregnant women. At-risk groups of pregnant women. Pregnancy is a risk factor for severe COVID-19 infection alone. Healthy young pregnant women with none of the below risk factors have a significantly increased risk of severe COVID-19 infection. Groups at increased risk include women in the third trimester greater than 28 weeks gestation or more. Pregnant women from Black, Asian and ethnic minority backgrounds are more likely than other pregnant women to be admitted to hospital with COVID-19 infection. Risk factors for serious COVID-19 illness and pregnancy include being over 35 and older, having a BMI of 30 or more, and having underlying conditions listed in Table 5A.2 of Chapter 5A of the Immunisation Guidance. In conclusion, you should target all pregnant women for COVID-19 vaccination and screen women with COVID-19 infections for comorbidities. At-risk groups of pregnant women. Pregnancy is a risk factor for severe COVID-19 infection alone. Healthy young pregnant women with none of the below risk factors have a significantly increased risk of severe COVID-19 infection. Groups at increased risk include women in their third trimester above 28 weeks gestation or more. Pregnant women from Black, Asian and ethnic minority backgrounds are more likely than other pregnant women to be admitted to hospital with COVID-19. Risk factors for serious COVID-19 illness and pregnancy include those aged 35 and older with a BMI of 30 or more and with underlying conditions listed in Table 5A.2 in Chapter 5A of the Immunisation Guidelines. In conclusion, you should target all pregnant women for vaccinations and screen pregnant women with COVID-19 infection for comorbidities. Benefits to the baby of COVID-19 vaccination of the mother in pregnancy. Children under the age of 1 are at higher risk of hospitalization and severe illness with COVID-19 infection. Studies have shown that COVID-19 vaccination in pregnancy reduces the risk of stillbirth by 15%, reduces the risk of babies being admitted to hospital with COVID-19 infection in the first 6 months of life. Young babies whose mothers were vaccinated in pregnancy were less likely to need hospital care with COVID-19 infection. Vaccination is low risk for the baby in utero. mRNA vaccines are not live vaccines, so cannot infect either a mother or her unborn child. The vaccine is rapidly broken down in a mother's body. It cannot become a part of the mother or the baby's DNA. Animal studies of the mRNA vaccines did not show any unexpected risks. There is no plausible biological mechanism which would affect the unborn baby or fertility. COVID-19 infection in pregnancy has a higher risk for the baby in terms of premature delivery, if the mother has severe illness, stillbirth, admission to the neonatal intensive care unit, and the potential for long-term sequelae for the baby of life-saving care provided or medications administered if the mother was admitted to ICU. Vertical transmission from mother to baby in utero is rare. COVID-19 infection in pregnancy does not increase developmental problems in the baby. COVID-19 infection does increase admission rate to the neonatal intensive care. COVID-19 infection in pregnancy may increase the risk of adverse pregnancy outcomes for the mother of being admitted to hospital, admitted to the intensive care unit, the delivery of the baby in ICU, placentitis, postpartum hemorrhage, hypertensive disorders, preeclampsia even in the asymptomatic cases, caesarean section in mothers with severe disease, and deaths from COVID-19. Mothers who are pregnant are at high risk of severe illness in the third trimester if they get COVID-19 infection. COVID-19 infection in pregnancy increases the risk of miscarriage. In the Omicron era, Mothers who are pregnant and develop COVID are less likely to have preterm birth or maternal critical care admission. What is placentitis? It is an inflammation of the afterbirth or placenta seen in the delta wave. It's a rare condition causing fetal distress and stillbirth in a number of women who had COVID-19 infection in pregnancy. It usually occurs within 7 to 21 days of COVID-19 infection in the second half of pregnancy, and it's unknown why it happens in some pregnant women. You should advise pregnant women, if they get the COVID-19 infection during pregnancy, that they need to tell the hospital to arrange follow-up, and they need to monitor fetal movement and attend the maternity unit if they notice any significant reduction in movement. There is no evidence that COVID-19 early in pregnancy is a risk to the baby later on. The proportion of pregnant women with symptoms and moderate to severe infection, a comparison by dominant COVID-19 variant. During the Wuhan wild COVID-19 variant phase, 24.5% of women developed moderate to severe disease. During the alpha wave, 36.2% developed moderate to severe infection, and during the delta wave it increased to 42.8% and dropped back again. A UK study of COVID-19 infection in pregnancy during the Omicron wave. In this study, they looked at the perinatal outcome of 3,699 women admitted to hospital during the Omicron era. They found most pregnant women admitted with moderate to severe COVID-19 infection were unvaccinated. The severity of the disease decreased with vaccination, highlighting the importance of completing the recommended course. Those admissions to ICU with moderate infection, the rates were higher in those unvaccinated or partially vaccinated. How do mRNA vaccines work? mRNA vaccines are inactivated vaccines. They are not live vaccines, and they do not contain any live virus. The vaccine is injected into the deltoid muscle. mRNA is like a set of instructions to our cells. mRNA stimulates the muscle cells to produce a protein which is harmless called a spike protein. The immune system recognizes the spike protein, responds with anti-production and immune cell response. There is no interaction with our DNA. The mRNA stays in the cytoplasm of the muscle cells. It doesn't enter the nucleus where our DNA is stored. Antibodies produced by the body cross the placenta and may provide some protection to the baby at birth. The mRNA in the vaccine is broken down in the body within 72 hours, and it contains no preservatives. What do we know about the safety of mRNA vaccines in pregnancy for the baby? There is now a growing body of evidence on the safety and effectiveness of COVID-19 vaccines in both animal and human studies, clearly indicating that the benefits of vaccination outweigh any known or potential risk of COVID-19 vaccination during pregnancy. COVID-19 vaccines have been very closely monitored by multiple agencies, including the World Health Organization, the European Medicines Agency, the FDA in the USA, and the MHRA in the UK. Hundreds of thousands of pregnant women have been vaccinated around the world in the USA, Canada, North America, Europe, Israel. No safety concerns have been identified for pregnant women. Professional organizations around the world strongly recommend COVID-19 vaccinations in pregnancy. These organizations include the World Health Organization, the National Immunisation Advisory Committee, IIOG, CDC, UKJCVI or COG, and the American College of Obstetricians and Gynecologists, and the American Colleges of Nurses and Midwives. What do we know about the safety of mRNA vaccines in pregnancy for the baby? Pregnant women were not included in the original trials. However, trials are now taking place in pregnant women. Multiple studies have now been published involving women who were pregnant when they received their COVID-19 vaccines or who became pregnant shortly after vaccination. These studies show that COVID-19 vaccines are not associated with increased risk of miscarriage, stillbirth, small for gestational age, preterm birth, or other adverse pregnancy outcomes. Some examples include a study of 105,446 pregnancies from the Vaccine Safety Data Link in the US, reporting that women who experienced a miscarriage were no more likely to have received a COVID-19 vaccine compared with those who did not experience a miscarriage. A registry from Canada included 30,892 women who had received COVID-19 vaccines in pregnancy, and there was no risk of stillbirth, preterm birth, or small for gestational age reported among 3,236 women who gave birth at the time of the study. Over 20 scientific studies in 8 countries in over 250,000 people vaccinated in pregnancy have found that COVID-19 vaccination is not associated with an increased risk of miscarriage, birth defect, stillbirth, growth problems in the baby, preterm birth, or admission to the neonatal intensive care unit. Studies from the UK, Israel, and the US compared pregnancy outcomes among women who received a COVID-19 vaccine in pregnancy and women who didn't receive a COVID-19 vaccine in pregnancy. None reported any increased risk of adverse pregnancy outcomes in the women who received the vaccine. Some of these studies found evidence that vaccination reduced the risk of stillbirth and preterm birth. In terms of miscarriage data, there was a study in pregnant women in the USA in 100,000 pregnant women and 28,000 in Norway, and this showed no increased risk with vaccination. A study in the UK of 180,000 women who received COVID-19 vaccine showed no increased risk of miscarriage, preterm delivery, low birth weight, maternal or neonatal intensive care unit admission, fetal death, fetal abnormality, or pulmonary embolism. A study in Scotland of 18,000 women who received COVID-19 vaccines in pregnancy showed no increased rate of stillbirth or preterm birth. A study of global COVID pregnancy register included 7,000 women vaccinated in pregnancy and found no increased risk of miscarriage, preterm birth, stillbirth, or admission to the intensive care unit. What do we know about the safety of vaccines for the mother? Common adverse events are the same in pregnancy as for others. Injection site pain, fatigue, headache, myalgia, arthralgia, chills, nausea, vomiting, axillary swelling, tenderness, pyrexia, and injection site swelling. These are usually mild or moderate in intensity and resolve within a few days after vaccination. For the new adaptive vaccines, they have a similar side effect profile to the COVID-19 earlier vaccines. What do we know about the safety of the vaccines for the mother? Very rare side effects include myocarditis and pericarditis. Up to 1 in 10,000 vaccinated people may be affected. It is more common as a side effect in younger men after a second dose, and the course appears to be mild and resolved with conservative treatment, as with myocarditis and pericarditis from other courses. Long-term follow-up of cases is ongoing. Note, COVID-19 infection is associated itself with myocarditis and pericarditis. There is no association between mRNA vaccines and clotting disorders. Thrombosis and thrombocytopenia syndrome is a very rare side effect of the viral vector vaccines such as AstraZeneca and Janssen, but not the mRNA vaccines. For more information on adverse effects, see the Immunisation Guidelines for Ireland at www.orcp.ie. What is my role? Make every contact count. Ask and check if vaccinated at every contact, antenatally and postnatally. Healthcare professionals are the most trusted source of information about vaccines. What you say and how you say it makes a difference. Recommend the vaccine. Recommendations by a trusted healthcare professional strongly influences vaccine acceptance. If someone is hesitant about the vaccine, the World Health Organization recommends a motivational interviewing approach. This is a patient-centered conversation designed to increase trust in vaccines, patient motivation, and the likelihood of health behavior uptake. And it is very similar to the making every contact count approach. It has been proven to increase vaccine confidence and uptake. First of all, how does the person feel about vaccination? Most people who are undecided about vaccines are not anti-vax. They are unsure, have doubts, or are worried. A very small proportion of people are against vaccinations or anti-vaccines. So on 2 poles, we have those who refuse all, I don't trust vaccines, or accepts all, I am ready to get the vaccine. And in between, we have those who are vaccine hesitant. They may refuse but be unsure. I don't think I'll get it. I'm not sure it's safe. Accept some, delay and refuse some. I don't know. I have my doubts. Accept but unsure. I think I'll get the vaccine, but I have some questions. So conversations about vaccine hesitancy involve skilled communication with a healthcare professional in order to influence decisions. If they're undecided about vaccination, use motivational interviewing. Ask open-ended questions. Can I ask what you're worried about? Affirm strengths. It's good that you're asking questions about the vaccine. Acknowledge and validate concerns. It can be worrying when you read things like that online. Reflect and respond. I understand that you want to make the best choices for you and your baby, but that you are concerned about X. Ask, provide information, verify understanding. Address the specific concerns and don't bring up new concerns, as this may help to propagate the myth. Can I ask what you know about COVID-19 vaccines? Can I provide you with some information based on what you've told me? How are you feeling about vaccines now we've had a chance to talk about it? Point to other sources of trusted information, such as the HSE website or the Royal College of Physicians Ireland website. Remember the positives. The vaccine protects against serious illness. Describe the action and leave the door open for them to come back. You decided to go ahead and get the vaccine, and you're going to make an appointment with your GP to get it. Or you're going to read the information I have given you and then talk to me about it again when you're back next week. Remember to recommend the vaccine for them and their partners, and if relevant, tell your own story. I got the vaccine when I was pregnant. For those who refuse vaccination, how do you proceed? Well, you need to take a non-judgmental approach. Statements like, I can see that you feel strongly about this and that you want to do the best for you and your baby. Ask permission to discuss COVID-19 vaccines in pregnancy with them. Would it be okay with you to talk about vaccinations against COVID-19? If they agree, offer information, and if agree, focus on their specific concerns. Can I ask you what your concerns are about the vaccines? Do not enter a debate or argument. I can see that you feel strongly about this, and leave space for any future discussions. Advise how they can protect themselves. Please know that if you ever want to talk about vaccinations, you're welcome to come back. It's really important that you try and protect yourselves against COVID-19 as much as you can. It is difficult to do, but avoiding crowded places, washing hands, etc. The goal is to maintain the relationship with the pregnant woman so the door is open. I'm happy to talk to you about it some more if you ever want to talk to me about it. These are some frequently asked questions. Remember to adopt a motivational interviewing approach whenever you're talking about vaccines. It's good you're asking questions about the vaccine. I know you want to do what's best for you and your baby. It can be worrying when you start to hear things like that. What are your concerns? What have you heard that worries you? Could I share some information with you based on what you've told me? I'm worried the vaccine is so new. How do we know it's safe for my baby? Although the vaccines are relatively new, they have now been given to millions of people around the world, including hundreds of thousands of pregnant women. The safety of the vaccine are very closely monitored for safety in pregnancy by national and international bodies, including the European Medicines Agency, MHRA in the UK, the CDC, the FDA in the USA, and the World Health Organization. This means that we now have lots of information about their safety. To date, hundreds of thousands of women worldwide have received a COVID-19 vaccine in pregnancy, and no unexpected pregnancy or infant outcomes have been seen. No safety concerns were identified in the study of women who got the vaccine while pregnant or became shortly after getting the vaccine, and no safety concerns were identified from these studies. There has been no increased risk of miscarriage, no increased risk of congenital malformation or birth defects, and no increased risk of stillbirth, no increased risk of growth problems, and no increased risk of preterm birth associated with COVID-19 vaccines. I have heard the vaccines can affect fertility. The mRNA that's in the vaccine does not go into the part of the cell, the nucleus, where our DNA is kept, so it can't affect fertility in any way. A number of scientific studies have shown that COVID-19 vaccines do not reduce fertility. Firstly, a number of studies have also shown that COVID-19 vaccines do not affect ovarian function, egg quality, fertilization, or the number of women who became pregnant. Secondly, there are a number of women enrolled in the clinical trials who became pregnant after getting the vaccine. The number of women who unintentionally became pregnant during the clinical trial was equal among women who received the vaccines and those who did not receive the vaccine. A large number of women have become pregnant since receiving the vaccine. COVID-19 vaccines do not affect male fertility. 3 studies have shown it does not impact on sperm quality or Can't I protect myself against COVID-19 in other ways? It is much easier for the virus to spread in the Omicron era and very difficult to avoid being exposed. All of these reasons mean that it's difficult to protect yourself against exposure to the virus. It's very important to follow the current public health advice and get vaccinated. The vaccine protects against infection if you get it and against complications for you and the baby. I was vaccinated before I was pregnant. Do I really need a booster? Yes, you do. The protection from the vaccine gets weaker over time. Because if you're pregnant, you are at risk of serious illness. It's important that your immunity gets a boost to give you better protection. The Omicron variant 2 doses may not be as protective against the new variant, and a booster dose gives better protection. And a second booster is recommended for all pregnant women, and a booster during pregnancy. Those who are pregnant should be up to date with their COVID-19 vaccine in line with current recommendations, including autumn and spring boosters, based on age and risk profile and time since prior vaccination or infection. Ask your doctor when in your pregnancy you should have the COVID-19 vaccine. Can I continue to breastfeed safely if I get vaccinated? Yes, you can continue to breastfeed. COVID-19 vaccines do not affect breastfed babies. There's no reason to avoid breastfeeding if you're vaccinated. Where can I find more resources? You will find resources at www.immunisation.ie, where we have a pregnancy-specific page. There is a questions and answers for pregnant and breastfeeding women, available at www.orcpi.ie. There is also a video about communicating with women who can be hesitant about vaccines in pregnancy, and there's also the guidelines from the National Immunisation Advisory Committee available on the ORCPI website, and there are also links to HSE and training videos for vaccinators, and there are also resources in different languages including videos, and you can see some of these below. This is the end of the presentation. Thank you for listening.